What is up? There's a handsome intensivist. What's up, Adam Green?
Not much. How are you doing, Haney?
Oh, it's good to see you. I'm doing great. Better than last time we were here. Last time we were here, winds were pushing, roofs were coming off houses. Literally,
Under duress, life threatened, right?
It was terrible. But none of that. Sunny skies and beautiful day, and always a good day for the Critical Care Lounge. So today we are talking about ECMO, extracorporeal membrane oxygenation, which is something that it always seems to come, like, Adam, how many times have you been talking to somebody and you talk about, refractory hypoxemia or refractory shock, and you just say the answer is ECMO, and it's something we always talk about, but the reality is that we kind of say it, but I'm not sure everyone truly understands A, what it is, and B, what's involved in it, and just how specialized care that is. Would you agree?
I agree. I find it's the flavor of the month. No matter what you start the conversation with, somehow it ends with ECMO, right?
Yeah, so it's like a little seasoning at the end. It's like ECMO, a little salt dab.
Yep. You talk about ultrasound, somehow we got to ECMO. We talked about ARDS, of course we talked about ECMO. So I think this session's probably overdue.
For sure. So we couldn't help but bring some pretty esteemed guests on tonight. And Adam, I'm going to turn over to you, let you introduce them, and then we're going to get right into it, into the questions. So let's go ahead and welcome our guests here tonight.
Welcome. So we have two guests here. So Dr. Emily Damath is one of our Cooper intensivists. She's an intensivist and a emergency room doctor, one of the ECMO specialists on our team, and who I call when I need help. And then we also have another Cooper grad, Dr. Terry Lonergan, and he. It sounds like he's been at several different places, amongst others. He was at Shock Trauma, and he's now the Deputy Director of Adult ECMO Services at Brooke Army Center. So I'm excited to pick their brains and learn a little bit about ECMO from them. Welcome.
Yeah.
Thank you.
We're glad to have you. Thank you both for being here tonight. And we're going to really get right into it. I'm also monitoring the chat for those of you at home. Please, 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 this is very interactive. Write your questions in. I'm typing way over here on the phone, writing back to you. But if you have questions, please write them, and we'll go at it, and we'll ask our guests some of these things. But let's get right into the questions. And I guess the easiest place to start is just with a basic question. If I'm an alien and I break atmosphere and I come to Cooper Medical Center and I go into the ICU and I see ECMO, just describe it for me. What exactly is happening in the simplest terms possible? And remember, I'm an alien.
Who's taking that?
I can take it, I guess. Okay. So even though you're an alien, if you have a heart and lungs, you could develop either failure to oxygenate or ventilate using your native lungs, or you could develop cardiogenic shock and sort of fail to circulate blood adequately to your organs, or you could have both. And so there are two different flavors, as we shall say, of ECMO, both veno-venous and veno-arterial. Where I work, we most commonly do veno-venous, so that specifically supports patients or aliens that have had lung failure in the sense that they can't oxygenate or ventilate. So it's essentially acknowledging that the lungs are not doing an adequate job removing CO2 and oxygenating, and so bypassing the lungs, so draining blood directly either from the internal jugular vein, the femoral vein, under negative pressure using a pump, pushing that through a membrane oxygenator, which has a gas and blood phase just like our native lungs do, to directly place oxygen into the bloodstream and remove CO2 through rapid flow of gas into the circuit that is 100% oxygen typically. And then that oxygenated blood returns to the patient in either the same vein using a dual lumen cannula or a different vein. So oftentimes we drain from the femoral vein and return to the internal jugular vein. In order to support a patient with circulatory failure, that's where you would drain deoxygenated blood similarly, and the pump would provide the negative pressure that then ultimately siphons the blood out of the patient and pushes it through the membrane oxygenator, but now you're returning blood to the arterial phase, and it's actually pumping countercurrent to the native heart. And there's sort of this mixing of oxygenated and deoxygenated blood that occurs somewhere in the aorta that allows then you to use that membrane oxygenator not just to deposit oxygen into the blood, remove CO2, but also to provide circulatory support. So then essentially your mean arterial pressure is generated by how fast that blood is flowing. So it's all dependent upon blood flow into the circuit, the gas exchange provided by that circuit, kind of like dialysis, it's occurring outside of the body, and then returning that blood to a vein just to support the lungs, or to the artery, femoral artery, to support the circulation.
That's great. So let me ask a question. To simplify, VV ECMO, lung failure, VA ECMO, heart failure. Does that mean if you're in shock, you can't go on VV ECMO?
No. So VA ECMO is going to work best for cardiogenic shock. Remember, there are four, and potentially obstructive shock as well. Many people who are in, vasodilatory shock because of the process that's going on in their lungs that's got them to where they can't exchange gas, go on VV ECMO, and that's the most appropriate form for them. If you put someone who's in vasodilatory shock, who may be hyperdynamic on VA ECMO, you can actually potentially make the situation worse, or at least need to adjust your modes to correct what you've done. So VA ECMO, you can define it a little bit more for cardiogenic and/or obstructive shock. VV ECMO is often going to be used to support folks who may be in vasodilatory shock but have a problem with gas exchange.
Right. So, I've always thought about a patient who's extremely acidotic from inability to clear CO2 or extremely hypoxic may have vasodilatory shock. And so, if the pump is working, stick with VV, right? Great. So if you're okay with it, I think VA. Oh, go ahead. Sorry.
Well, yeah. One thing, if you're sitting at the bedside and you're trying to figure out, geez, should we go on VV or VA? It's to go on VV. You're going to put 2 holes to peripherally cannulate. Simplest form VV ECMO. You're going to put 2 holes in 2 veins. It's a lot easier to go from VV ECMO to VA ECMO than it is to go from VA ECMO and then decide that you don't like what you did and go back to VV ECMO. Because that's often going to involve going in the OR and getting a decannulation that way, depending on how you're doing it. But so if you're in doubt, and the patient's not in cardiac arrest, we're not talking about ECPR. That's always going to be VA ECMO. If you're in doubt, start with VV ECMO as a general rule.
I'm a pulmonologist at heart, so I like that. Fix the lungs first, worry about the rest later. Yeah. Love it. Let's focus on VV. Emily, can you go over just the common indications? Which patients are the ones you're thinking, oh, I need to transfer them to a tertiary center. Oh, I really should be thinking about ECMO. Maybe break it down into 2 or 3 most common reasons you're thinking about ECMO.
Yeah, I mean, it's hard not to lead with the pandemic going on with COVID, but in general, ARDS. So most often caused by a pulmonary process, although it could be an extrapulmonary process, whether it's acute pancreatitis or massive transfusion, the trauma patient with pulmonary contusions. We're most often utilizing, VV ECMO for severe ARDS. There are certainly other causes of respiratory failure that cause large degree of shunt, like, you could have sort of particulate aspiration. We had a patient who aspirated a bag of peanuts and really just one lung was affected. But in general, patients either go on because they're severely hypercapnic and acidemic or hypoxemic, and that's often, especially with hypoxemia, due to shunt physiology. So most commonly, I would say it's the patient with severe ARDS that then you optimize them from paralysis standpoint, inhaled pulmonary vasodilators, prone positioning, and they still fail to oxygenate or ventilate. And usually we're talking about, PF ratios, if they're on 100% FiO2, having PO2s under 80 for 6 hours or so, or under 60 for 3 hours, or having a pH under 7.2 and an elevated CO2 such that they can't ventilate. Those would be our most common indications, I would say. I don't know, Tara, if you want to add anything to that.
Yeah, I mean, that's the for VV ECMO, and those were the criteria for entry at the Aeolia trial, which is sort of the last landmark trial that came out about 3-4 years ago, something like that now. So right, and then of course having a decent chance of benefiting from VV ECMO. I don't know if it's time to talk a little bit pre-COVID versus COVID now about what your criteria are, what our criteria are. But certainly, I'm getting multiple phone calls a day at this point. I'm working in Texas, so across the South we've got just not enough ECMO beds for the people who could occupy them. Generally, you're looking at folks who meet the oxygenation and or lack of oxygenation and lack of ventilation criteria Emily just gave, but also for VV ECMO, usually Previously, a regular flu year under 65. No major comorbidities. They can make a good functional recovery. So not somebody who's on home oxygen. Usually not a dialysis patient. And never a dialysis patient. Nobody with cirrhosis. Or advanced cancer, that sort of thing. We usually want them to be on the vent somewhere. Different centers will use different numbers, less than 7 to 14 days. I mean, at my previous institution, we were usually somewhere around less than 10 days. A little bit of shock is okay, but we need to be able to get you to us, and we have to not think that you're going to die imminently. Certainly acute renal failure is fine. Somebody who's on CRRT, because of their disease process, we would do that. BMI, interestingly, not really a showstopper for us previously. There is literature that, BMI out to, even in the 50s and 60s, people do just as well. I will say, at least for us right now, COVID has changed the game. Because we are absolutely, inundated with calls. And so we don't want to put, I can't put, good candidates on ECMO. I have to put absolutely ideal candidates on ECMO. So, we've really tightened up our criteria down here. And so we're, right now we're sort of age more than 50. If you're on the vent more than 7 days, if you have if you're not single organ failure, it's a no-go for us right now. That's where we are. I don't know what you guys are doing, Emily.
Yeah, so I think sort of working through some of those same challenges, I think that we similarly have been inclusive of high BMI patients, and chronic organ failures are patients that are typically excluded, malignancy typically excluded, although we have had some liquid tumor patients that have survived and thrived after ECMO, or at least one that I can think of. But similar. I think the question of support prior to cannulation is a very challenging one. Certainly the 7-day threshold is something that we have used for invasive mechanical ventilation, but many of, with respect to COVID, are often supported non-invasively and have substantial needs for a long time, either high flow or BiPAP. And, I think our group started to become concerned that, those days, why maybe not as equal to risk of VILI or ventilator-induced lung injury as invasively mechanically ventilated patients, those days of non-invasive support we tend to count. So we're sort of looking at, and we don't have like a strict absolute, but in general, we like to avoid invasive mechanical ventilatory support for over 7, definitely over 10, and then the non-invasive invasive combo under 14, as long as that invasive portion hasn't been prolonged. But I think that in general, these COVID patients, and we're learning more and more, the second wave, the survival has not been as good. I don't know if that's due to increased reporting or increased utilization at sort of smaller ECMO centers. But the survival of patients that are cannulated for COVID ARDS as opposed to another etiology is much less. And it's looking like it's under 50%, and it may even be 40% or lower survival. And so that certainly has to be taken into account for patients that are clinically frail, or, it is a very invasive way if there's not a lot of recoverability, because I 100% agree with you. That is the ultimate goal, is recovery, not just survival. If the risk of prolonging death is high and not recovering, those are patients that we like to avoid. I think that this decision of who to cannulate and who not to cannulate is one of the hardest in ECMO, because sometimes patients we anticipate won't do as well, they do better than the young, healthy patients, and with COVID, and that's a good challenge.
Let me ask you both a practical question, if you don't mind. So, this is always, a hospital's calling you. You screen them on the phone. Let's say it's a little hospital. They have someone who sounds like they're a good candidate. They haven't proned. They haven't, they haven't let's say done, they haven't been on high flow or they just recently intubated. Walk me through the person who you would bring to your institution, not necessarily cannulate them, because I know we want to talk about cannulating people, but which is the person that you'd bring to your shop saying, I'm going to bring this person here, I'm going to work with them for a fixed period of time, and if they fail, this is a good candidate for ECMO. So you could bring it as to like maybe the person just landed on your doorstep or if they're getting transferred over. But I just want to hear, obviously we know from the Caesar trial that we don't just immediately cannulate people that come over, but there are things that we do at the big centers that are done better than the smaller hospitals. Walk me through and tell me what you do for your patient in ARDS before you cannulate.
Yeah, I mean, it's a great point. And when you're on the phone with folks at smaller hospitals, you're often trying to feel out, how much experience they have, what's available there. Does the person who's giving your description of the patient seem like they're comfortable with what's going on? But as Emily said, typically we're going to maximize support. Pretty much everybody who goes on, VV ECMO for acute respiratory failure is going to have a trial of proning and paralysis, is going to be on some sort of ARDS-net like vent settings and or APRV and or depending on where what you like or your flavor. I came from shock trauma like you, Haney, so the APRV may cure all things, right?
Yeah, right.
Just inhaled vasodilators if they're available. But very much since you began with, well, tell me what I'm thinking when I'm talking to somebody else in the community. I'm often trying to get a sense of what's their comfort level with what they're doing. How far away are they? That may involve the weather and what transport facilities, depending on where you are. What are the consequences of leaving them there?
So let's say that you're going to bring them over to you. What I really want to get in your head and figure out what you do is how long do you take that person and do you try to optimize them before you decide that it's time to go ahead and put them on circuit? Is there a number of days from when they arrived at the hospital, any ventilatory support? Is it how many days they're with you until you can apply your expertise to that person? And that could be for Emily or Terry.
Yeah, I mean, I think, if they're rolling into the room right now, I kind of like to play with the ventilator a little bit, as I'm sure Terry does. So like he said, getting them on a lung protective tidal volume, which, oftentimes that's the first step. Like the patient hasn't been actually measured. So getting their height and calculating their predicted body weight and putting them on a 60 cc per kilo tidal volume. And if our plateau pressures are still over 30, kind of walking that down and then trying to titrate PEEP. We typically use driving pressure. So think about that pressure, that distending pressure across the alveolus that's cyclical, subtracting that PEEP you're setting from the plateau and you're trying to get that number under 15 centimeters of water. If you can get them to a lung protective tidal volume and a lung protective driving pressure, and now you can prone them and put them on inhaled vasodilators and their PaO2 goes up to 90, we're going to watch that for a while, especially with COVID, and really trying to, we've been pretty strict about actually meeting inclusion criteria for the RCT in the New England Journal that Terry talked about, that really, waiting till they meet criteria. You don't want to use ECMO as a salvage situation where someone's peri-arrest, but really we have seen many patients avoid it by doing the dedicated manipulating the ventilator and proning, and we're in a different place, 16 hours later, and we just might avoid it in something that we always kind of have to explain to families who are told you're going to an ECMO center. The goal is not to be on ECMO. In fact, if you can survive without it and recover, I think that's probably ideal, especially with COVID. So I really think it's kind of working through lung protective driving pressures, plateau pressures, tidal volumes, and then proning and seeing where you're at.
That's very
Completely agree.
So I'm gonna, before I ask my question, I'm gonna tell you what keeps me up at night, and that's pulmonary vasodilators, because they scare me, because I know that they don't help outcome. I know that, yet they for sure at times knock you out of the ECMO candidacy, and ECMO maybe does provide improvement in outcome. So,
so you're the one hiding all the medications.
Yeah,
around,
I'm the one who just goes and discontinues it on every patient. So that's
enough.
the question. I don't know, but it scares me. But for transport, 100% agree. Okay, so the 25-year-old ARDS, BMI is 28. Her PF is 60. She's been prone. She's Nimbexed. You got all the goods on her. You decide to cannulate. What's the approach? And
you mean what's the approach, or what is
who's doing it? Where are you doing it? Where are you putting it? What size?
Yeah.
How do you think about size? Do you do dual lumen? Do you do whatever you want?
Yeah. You want me to go first, Emily, or then right. So dual lumen cannula were I don't know, 10 years ago when I first started reading about ECMO, they were kind of like the new thing. It's a cannula that is generally placed in the IJ, and you can take the blood out from the SVC and the IVC, and then infuse it right back into the right atria through a second lumen in the cannula. It's a 31 French cannula. It's got a number of brand names. The most common brand name is Avalon. I don't take any money from anybody. I should probably also say that these are my opinions and not those of the DoD or the Air Force, so nobody gets in trouble.
Well said. The disclaimer.
Thank you. But anyway, yes, you can use a 31 French cannula, and that'll do both. Both the taking the blood out and putting the blood back in, and hook that right to the pump. And the advantage of that was that you could get patients more mobile on that, and it was people just thought it was a better way to go. In my previous institution, Maryland, I'd say I never saw one in 4 years there. And what they didn't like before I got there, they had some experience with them, was getting them to flow. And as Emily probably knows, you have to have the cannula oriented so that the return flow is oriented right at the tricuspid valve, and that can sometimes be tricky. So we did all our cannulations were a drainage cannula and a return cannula that was separate, and I'd say 90% of them were a femoral drainage catheter with usually a right IJ return catheter. And we would get people up and walk them around and rehab them with that, and it was no problem. People get nervous with femoral cannula, but it works just fine if you've got them secured well. In my current institution, we do most of our cannula are actually fem-fem. And again, we get people up and walk them and rehab them. The typical ECMO is preload dependent and afterload sensitive. So the pump needs preload. So the thing that's mostly going to limit your flow on the pump is the drainage cannula. You need a decent intravascular volume to support it, and a decent sized drainage cannula. For most adults, that's going to be for us a 25 French drainage cannula. But if you want to measure, you measure the vessel, and it can take 3 times the diameter of the vessel is what the vessel can take. So if you have a 1 centimeter vessel that's 10 millimeters, you could potentially put up to a 30 French cannula in there. But we're usually going to use a 25 for drainage. I don't know, Emily. What's your guys' favorite approach?
I think similar. I think most commonly the configuration is drainage from the femoral and return to the IJ. Mm-hmm. There's been specific populations where we have used an Avalon, and I have to say that's not something I've personally placed, but a couple of our colleagues do it, and we do it under TEE guidance. And for instance, the pregnant patient, we had a patient in sort of late second trimester thinking that drainage perhaps would be impaired by the gravid uterus and increase intra-abdominal pressure. And I think that, and also just the bleeding that would occur cannulating a compressed vein coming off the IVC. So that, that's one example. In a morbidly, have had morbidly obese patients where we have done an Avalon catheter or cannula, although there you do get into high body surface area, requires more flow, and sometimes there are limitations. So just to reiterate that point for the listeners, I think that's just so crucial that, we think about lung compliance, and when we're thinking about the native lungs and ability to deliver a tidal volume and gas exchange, when we're thinking about the circuit, it's all about blood flow. And really wanting to maximize that drainage cannula size, not completely obliterating the vessel, but that's essentially just how much oxygenation you can get is how good your blood flow is. So I would say that we're pretty similar in that regard, that you spoke about measuring the internal diameter of the vessel in millimeters and tripling it as sort of the max French diameter of the vessel, and then maybe a size down or two from there. But really the largest one that we can get in for drainage.
Yeah. So let me ask a question, because you get this person on ECMO, the flows are going, the blood is bright red. Anyone that's put someone on ECMO knows there's like this satisfying bright red blood that's going through the circuit, and the sats come up and everyone's high-fiving. There's this feeling of good in the room. But there's a long road ahead. There's many more things to be done. One of the things that I see varying amongst institutions is, where do you set your vent? And that's something I'm curious to hear. Tidal volumes, modes, minute ventilation. I've even heard of some places just really turning off the vent. So I want to hear what you all are doing and what you believe to be best practice. Emily, why don't you start us off?
Okay. I think one of the most urgent things is, once you're on circuit and you start ventilating via the circuit by titrating up your sweep gas flow, which is just the gas running through the circuit, creating a greater CO2 transfer, you don't want to plummet your patient's CO2. So, they may be very acidemic with a CO2 of, 80 or 70, and we don't want to normalize that, especially right away, if at all. And wide swings in CO2 or rapid drops in CO2 post-cannulation can lead to, at least associated with intracranial hemorrhage and some danger there. So really trying to be judicious up titrating this gas. And so pretty soon after cannulation, while we're still in the room, we typically would start to turn down the ventilator. I don't want to get into a ton of primary literature, but this concept of there's lung protective ventilation, 6 cc's per kilo ideal body weight, and then sort of ultra lung protective, whether that's 3 to 4 cc's per kilo. And is there a benefit of that? And I think the jury's a little bit out on that. But in general, we want to now, if we couldn't meet our safety goals with respect to driving pressure and tidal, we need to now meet those. We usually use the pressure control mode, where we're kind of, in so doing, you're kind of setting the driving pressure. So if you make your peak airway pressure, 25 or less, you're sort of limiting your peak alveolar pressure to that high. And then if you stay on a PEEP at 10, then your driving pressure is right at 15, or even getting it below 15. So we wouldn't want the driving pressure over 15 post-cannulation, and that ECMO allows you to scale back on that, because you're now ventilating via circuit. But we in general want to maintain that PEEP. PEEP is therapeutic. Unlike a high tidal volume and high airway pressures, PEEP sort of opens up derecruited lung and collapsed alveoli. So, keeping at least around a PEEP of 10, or in a morbidly obese patient, maybe even higher than that, where the pleural pressure is very high, the chest wall is very heavy, and there's a tendency to derecruit. So I would say, in general, post-cannulation, be careful about not just maintaining where you were on the vent and then rapidly titrating up sweep gas. You don't want to plummet the CO2, but kind of changing modes or becoming more ultra protective with your tidal volume strategy if you're using volume control, or in the case of pressure control, maximizing your plateau pressure at around 25, and then really the low lung compliance kind of takes care of that lung protective tidal volume from there.
Awesome. How about you, Terry?
Yeah, that is the question. Is what to do.
I ask these questions.
What to do? Yes, you do. You can I go now?
These are the hard-hitting questions that people want to know, Terry.
If I knew the answer to this question, and how to predict what to do with which patient, right? That's the question, right? Dan Brody's great review article from about 2015 New England Journal. So Brody, New England Journal, for the listeners out there. Extracorporeal membrane oxygenation is, I think, the title. The famous line is often quoted: the optimal vent settings for people on VV ECMO are unknown, and we don't know what vent settings and who. Is it even important to keep the lung recruited? It's definitely important not to drop the CO2 too quickly. There's some literature recently, as Emily is aware, that dropping CO2, wide swings in CO2, you get CNS side effects, and they're associated even with outcome. So lowering the CO2 slowly is a way to go. But I got to tell you, in Maryland, we would cannulate somebody, we'd get them stable on ECMO. The sats would come up into the 90s, and we would take the vent and set it pressure control, PEEP of 10, a 10, driving pressure of 10 above that, a rate of 10, and 40% FiO2, and we would leave it there. And since we did that for everybody, it can't be right? Because there's no way that's right for everybody, right? But we were definitely into and we didn't care what the tidal volumes were, right? You could have tidal volumes of 2 cc's. You wouldn't usually see 2, but you might see 10 or 15, where they would have to put the vent in a pediatric mode, and the lungs would collapse, and then we would just let them ride, and over weeks to months, many of those 60 to 70% of the time they would come back, right? Because that was our survival. But our current institution, we're actually fairly aggressive about extubating people early, and I don't know if it's the right answer. And I'm still trying to get our head around who it's the right answer in. Extubating folks lets you, the ET tube is out. You can shut off all the crap you're giving them, all the fentanyl, all the propofol, or a lot of it usually. Try to manage the tachypnea, but then you can wake them up, and a lot of people can be rehabbing. But some people, again, still are limited by tachypnea, and we've had to re-intubate some folks for airway toilets. So it's a tough. Nobody really knows the answer to that.
It sounds like you guys are.
Segue, then tell me, how do you approach sedation? And that's probably the second impossible question to answer.
Right.
What's your use of paralytics? What's your sedation approach? Because I'll be honest, the ECMO cannulas come out 100% of the time before the ET tube does at Cooper. We have yet to have that experience.
Right.
You read about literature about trying to turn up the sweep gas, drive down their PCO2, limit their respiratory drive. We've had variable success in certain populations. Yeah. But how do you get them off sedation practically? Because generally they breathe 100 times a minute, and it's very challenging.
Right. Yeah, it's difficult, and sometimes you have to look at things you don't like to look at. And you're right. So you'd think, you've got somebody with a normal blood gas in front of you who is breathing like a neonate, right? I mean, they're breathing, just with ridiculous tachypnea, and you think, well, why would they do that, right? It's CO2 is the main, pH in your pons or your brainstem somewhere is the main driver. So why would they be doing this? But it clearly has something to do with your lungs being full of fluid and some or whether it's COVID driving some of it. There's a CNS effect. But generally, so on ECMO, we don't paralyze anybody unless you can't flow. Unless you're coughing and so desynchronous that that the circuit can't flow, and usually that we can get through that in the first couple of days as we settle you in. We are fairly aggressive at my current institution with, again, trying to wean pretty much everything. We like dexmedetomidine, but trying to wean certainly fentanyl, stuff that stays in lipids for long periods of time and causes delirium and causes problems on day 28 when you're on day you're on hour 8 and you're trying to figure out what to do. We're fairly aggressive about weaning propofol, fentanyl, ketamine. We're pretty much benzo free. We try to be, certainly, and trying to move towards extubation. And if we can't quite get there, we'll often early trach them, so we can get that ET tube out of the mouth, and then we can shut off the stuff that lets lets them wake up. And because again, the goal is to have them rehab, right? For us, I mean, that's sort of where we want them to be. We want, if ECMO is going to provide an advantage, it's going to be that you're going to be able to walk to rehab rather than be wheeled to rehab because you spent 14 days prone and under basically general anesthesia. That's where we find some of the biggest benefits. So, does that answer the question? I mean,
yeah. So you push oral agents, probably. You use some.
Sure. Well, I mean, we try to limit narcotics if we can.
You let them breathe fast as long as the ECMO is running, and
we do
mess around with pressure support, or you just pull the tube out if the gas looks okay. I mean, how? Yeah. I'm just trying to think about
if your mental status is okay, really. You got to be able to protect your airway. I need you to be flowing on the circuit, right? I can't, and we're fairly aggressive about getting stuff off, and many patients will find that for 3-4 days they can look rough, but we've got the nurses now where they've bought into getting in there and just redirecting patients and reassuring them through it, and many people will settle in. We use a lot of some antipsychotics and small boluses of things like fentanyl and stuff to get over a hump. Sure, permitted, but we are fairly aggressive about more aggressive than I think most centers. I don't know that it's entirely the right answer all the time, because the question then becomes, is having somebody who's breathing 60, are they injuring their lungs? That's a bigger COVID question, right? I mean, is having that guy on BiPAP for a week, taking those huge tidal volumes, is he hurting himself, or should we be doing something different? But anyway, that's our approach currently.
I'm thinking about your population. They're probably young and in shape, and probably slightly different than my Philadelphia.
So we're a military hospital. We've actually got a secretary, what's called a secretary designee program. So we take civilians down here. So we go to local hospitals within 185 miles. We can go get people, and of course we do all the retirees and stuff. So we've got a smattering. I do have some young, healthy, unvaccinated military people on right now, but we've also got some people who are not young and healthy.
Well, I'm going to keep it rolling, but it's official. I'm going to let my wife know that I'm going to come out and hang out with you on my next vacation, because I gotta see this. It sounds amazing. Emily, let me know. Tell me now, and I don't mean to steal all the questions, Danny, but you've decided they're ready. How do you know they're ready? How do you get them off? Kind of what's that approach? How do we end this ECMO segment of their stay?
Yeah. Oh, sorry.
Go ahead.
No, go ahead.
So one thing I just Terry brought up, just two concepts that I find fascinating, or questions I don't think we know the answer to. So I just want to say it real quick. And the one is a rested lung an inflated lung, or is a rested lung, do you allow that atelectasis? And that's, I'm a simplistic person. In my other life, my basketball was my favorite thing in the entire world. And I can tell you that when I went on a vacation and brought my basketball so I could practice dribbling, if I deflated it, it never pumped back up right. And part of me wonders that if you totally let someone collapse, is that good for the lung? And I know that the APRV enthusiasts would argue, no, a rested lung is actually an inflated lung. And part of me wonders the answer to that. The other question I think Terry raised is like a great one. I mean, I honestly think that what you're describing is being on low sedation and is kind of the goal. Now, whether a patient can cause self-induced lung injury by thinking negative pressure in the pleural space, now that's just all additive to alveolar distending pressure. So even though they're negative pressure breathing, they can generate very high transpulmonary pressures. And so this concept of like, is intubation somehow protective because you can limit that? And then the power of just breathing, that frequently, I don't think we know the answer. And I wish that there could be a randomized trial to that approach. And I also wish that to be honest, I think we've sort of struggled with that, especially with the COVID population, waking them up and et cetera. But with respect, no collapse ever, straight from Dr. Puri. With respect to weaning, so wanting to come off ECMO, that was the question I was actually supposed to answer, right? Yeah. So they start to, what happens is you notice with their blood gas that, you're able to keep weaning that sweep gas flow. So they might be on 8 liters of sweep gas flow, and then now you're coming down and your CO2 isn't rising, and you're able to wean that sweep gas flow down a couple of liters, and then you're getting close. Also seeing you're oxygenating better. So being able to lower the FiO2 on the ventilator, you can actually turn down the percentage FiO2 that you're delivering with the ECMO circuit, and they're tolerating that. And then you can wean the blood flow. But again, as Terry emphasized, blood flow is key to ECMO, and you certainly don't want your cannulas to clot. And patients with COVID in particular are prone to clotting, not only cannulas, but the circuit, the membrane oxygenator. So what we tend to do is wean that sweep gas flow by 1 liter a minute every 30 minutes to an hour. And we would like to eventually get that totally shut off. And in that sense, you're not oxygenating the circuit, and you're kind of effectively weaned from ECMO. Now you can wean the blood flow, but we like to get that to a nadir of around 3 liters a minute. We don't, 3 liters, because we don't want to clot off the circuit. So you don't really want to wean that flow to stand still. So essentially, that when we're doing that, we're now going to, just like when we cannulated, we went down to more protective settings on the vent. Now we're going to kind of come back up. And at least try to still be lung protective, but get back up to the 6 cc per kilo tidal volume, letting the rate rise a little, keeping it under 20 or so. I mean, these are just sort of thresholds, still maintaining your PEEP because it's therapeutic. But ultimately, if you're able to totally wean off your sweep gas, now your circuit is not really providing gas exchange, and we tend to, then you're sort of just recirculating, right? So the blood is going through, but no gas exchange is being performed mechanically. And then we tend to recirculate overnight and prepare to decannulate the next day, depending on the timing. But that's usually our stepwise approach, just seeing that the patient can tolerate weaning that sweep gas, they're still ventilating, then you're turning down your FiO2 on the ventilator. And as you cinch off the sweep gas flow, you're sort of effectively limiting the amount of oxygen that the circuit is giving as well, to allow you to wean and then decannulate, which is a very exciting day.
Is that about what you all do? How do you?
Yeah, agreed. And again, just to emphasize a couple of things Emily said, and because I know there's folks at all levels listening to this, the oxygenation is controlled by the flow of blood on the circuit, right? So if you're on call at night and the ECMO patient is desaturating, the answer generally is not to go to the ventilator and start doing things on the ventilator. The answer is to look at the blood flow on the circuit. That's why we want good blood flow through the circuit. And really what controls the oxygenation, the systemic oxygenation of the patient, is the ratio of the ECMO blood flow to the patient's total cardiac output. So for instance, if you're pumping, you have maybe a young person who's can generate 10, 12 liters of cardiac output, and you're flowing say 5 liters, you're capturing 50% of what's going through their right heart and their left heart, because they have to be the same every minute. So your sats are probably going to be below 90%. Because if that ratio is usually if you can hit about 60% or so, you usually be at SATs in the 90s. But again, on ECMO, you can tolerate SATs in the 80s, even the high 70s, as long as the patient looks okay. Because again, they're going to get 5 liters of fully oxygenated blood every minute. So there's room to live in there. But again, so oxygenation controlled by the flow on the circuit, not the ventilator generally. CO2 controlled by the sweep gas, just as Emily said. And for the beginners out there, those really are the concepts that you have to cement in your mind. But yes, that's a very similar approach to what we do. And as you get close on your sweep gas as it's coming down, typically I also, if you're on a ventilator, we've got a trach in, we'll maybe we've got some room to go up on the vent, maybe add some more PEEP, but still we're not gonna be on insane settings. We're going to be on reasonable, very lung protective settings and something, pressure support,
And
but
when
yes,
you're turning down your sweep, right? Are you checking a gas and then making a vent adjustment, or you're guesstimating your vent adjustment and then getting a gas based on that?
I'm not making any vent adjustments generally as I'm turning down the sweep.
Okay,
I'm
so you're making
coming down on the sweep. I'm coming down on the sweep, and then I will get a gas, right, and see what the effect was. Now, I see what
because the settings that you did initially, right? The settings that you did initially were very they're very kind of weak, right? I mean, you're protecting the lung, you're ultra protecting if you're going for the 2 to 3 cc's per kilo. So then if you're dropping the sweep and you find your gas is terrible, have you proven that anything's better? So I assume that you're increasing your minute ventilation at some point.
Yeah. If I'm getting close, okay. And there's a number of things that are going to help me there. The chest X-ray is clearing, right? First of all, the patient is out of shock and is stabilized, right? And I'm usually at least several days, if not several weeks, a month, 2, something like that, Emily. Right? I mean, sometimes these are long runs into this, but the chest X-ray is looking better.
Yeah. We're talking about the person where you can see the runway, if you will.
Yeah,
now you're trying to figure out if you can land. So
the sweep is starting to come down.
Right.
The suctioning requirement has gotten better. We've gotten them aseptic. I'm down to maybe 1 liter per minute of sweep, something low. Okay, but if I'm still on very, very low vent settings, and my tidal volumes aren't that good, well, okay, I'll go up then I'll go up a little bit on my PEEP, go up on my driving pressure a little bit, try to achieve. Oh, look, there's a more human tidal volume for this adult person. Does that allow me to then shut the sweep gas off?
Right.
And again, I'm going to base that on blood gases, right? That's how I'll know whether my experiment is successful.
Awesome. All right, and then you recirculate, as Emily said, and then decannulation, right? It's so simple, right? How do you all decannulate? I know obviously if it's centrally placed, right? So if it's in the OR, they're going to go back to the OR. Anything in particular that's different, or is it just pull, hold pressure, who holds pressure? Like, these are the nuanced questions that I'm really interested in. Does it have to be a physician? Can it be a nurse, or or can it be the perfusionist? Walk me through the process of getting the cannulas out. Emily, why don't you take us there?
Yeah, so we tend to do it bedside. We really like to involve our fellows in both cannulation and decannulation. So getting a team, if you have a dual site cannulation, so involving your IJ and your femoral, getting a team of like a fellow and attending at the IJ, a fellow and attending at the femoral, you should be weaned to zero sweep. You've been recirculating. Stop heparin or bival or whatever you have running for anticoagulation or not. Well, we would stop it, but if maybe you didn't have anticoagulation running at least a few hours prior. And then, you want to make sure that you're doing the safe things, right? So that you've got fluids or pressors in the room. Not that we've really had to use those, but I feel better about that. If they're on CRRT, I like to rinse back the blood volume. Maybe I'm being conservative there. And then increasing the ventilator FiO2 to 100%. Just for the procedure itself, and making sure the patient's adequately sedated and getting analgesia for that procedure. And then we, depending on which vessel you're removing it from, if you're taking it out of the IJ, you're going to be in Trendelenburg, and then vice versa. We like to place sort of a purse string suture that's just sort of shaped like a box, and you kind of pre-throw that so that as you pull that very large cannula out that looks about the size of a chest tube, there's a fair amount of bleeding. So someone has to be ready to tie that down and get hemostasis. So that's sort of the technically riveting part of the procedure, is that there can be a fair amount of bleeding in that if you're not ready and don't have your sutures thrown, and then we do a couple throws and add to that, put another purse string in if we need to, and then kind of repeat that at the other site. And we always have our perfusionist there as well. In New Jersey, we always actually have a perfusionist at the bedside. We have wonderful perfusionists at my institution, and I've learned so much from them and still learn from them. And so they're very intimately involved in that as well. And really, it's like an awesome moment in the care of the ECMO patient. It's very much like, my favorite procedure in all of critical care is extubation, because it takes someone from being critically ill to, they may be able to watch TV and talk to you. And so getting someone off ECMO is just like this really awesome moment that's punctuated by a little bit of bleeding.
That's awesome. Yep. I totally agree. And if I hear you correctly, it sounds like you do it at the bedside in the room. You're not traveling anywhere. And by the way it sounds, you yourself, the intensivist, is doing it, which is just wonderful. So we're running out of time, and I want to make sure we have time for any questions out there. But one last, what's the future of ECMO? Let's say COVID dies down. Where do we go from here? Is VV in? Are we? I think all four of us are we're addicts, and so we're going to say yes. But where do you guys see? What do you think is going to happen?
We've circled back to your first question, I think, because you said if I'm an alien, right, and I come down here, because I use this example when I talk about ECMO, when I'm trying to convince folks where I work that we need to invest in this. I think 10 or 15 years ago, it was like, the Martians are landing and they're putting people on ECMO. It was this weird thing. That's really crazy. That's only at very, very specialized centers. ECMO utilization, though, has increased. You look at the ELSO data, like 30 times in the last 10 years. The amount of literature on ECMO has exploded. I think it's 15 times in the last 10 years. This is now part of regular old critical care, just like sort of having access to your trauma center is part of regular old critical care, right? If you're in a small hospital somewhere, in a rural area, you may not be the trauma center, but I think probably every hospital like that has thought about, how would I get to the trauma center if I have a bad trauma patient, right? This is now becoming just kind of a regular old acceptable thing, and knowing how, if you don't do ECMO, and not every place will do ECMO, in the near future, but you have to know how to access the system, certainly, because this is becoming, it kind of already is just a regular old part of critical care. It seems like a big deal when you first start doing it, and it is a big deal. But as you get more facile with it, it gets easier and easier. I think the equipment's going to get smaller, and that's going to allow more places to do this. Certainly, there'll be more places initiating this, because it's usually not an emergency to transport someone on ECMO. It's an emergency usually to initiate ECMO. You will see more ECMO centers, year by year. I don't know. What do you think, Emily?
Yeah, I totally agree. I mean, it's fun to look at those curves, and 2009 ECMO, skyrockets, H1N1, and I think I haven't really seen a zoomed out view now that COVID has hit, but I think if anything, it's going to be even more exponentially greater the utilization. And I think it's miraculous in so many cases, just like show-stopping miraculous what it can do for patients. I also think, and as it's coming out in the lay press more and more about ECMO, there are, risks to it as well. And I think we all know that. We didn't talk a lot about bleeding and clotting, but just like you have barotrauma and ventilator-induced lung injury, there are bleeding catastrophes and clotting catastrophes that can happen. And so I am very much an enthusiast, but I think we all with ECMO just think so hard about when to cannulate and when not to, and what are the risks, because it's a very invasive way to support someone. I agree that it seems like just like much of medicine, it will get more minimally invasive. But I'd like to have a better understanding and more study of, what should our inclusion and exclusion criteria be, and how can we better predict who can recover, and the nuance of the ventilator and all the management. And I hope that most of the ECMO literature is retrospective, and it's wonderful from the ELSO registry, but we're starting to see more and more prospective trials, and I'm hoping that that's what's to come. Because as enthusiastic as I am in many patients, sometimes we feel that we should try to avoid it, that maybe a patient wouldn't do well on ECMO, and the risk and the complications that ensue sometimes. So I'd like to better understand who is going to miraculously benefit and who could have a life-ending complication, and that's a tough one.
I think it's just going to come with time, time and expertise, and our data set getting bigger.
Also, though, we're going to have to be psychologically, and if I might say spiritually mature too, because there are people who are going to be supported on ECMO who are going to come to a point where it's not a destination therapy, and they're not going to have a way off. And as more and more people get put on ECMO, you will have more and more people who then come to sort of particularly VVs, it's a dead end road, and we're going to have to figure out what to do in those cases. And most of us have seen cases where somebody's on VV, they have no way to transplant, they have no way off the VV circuit, and it's not a destination therapy. Yeah. And it can be a very difficult ethical challenge as to what to do then in that case. And again, it's like anything else in critical care, right? Critical care does some wonderful things, but it also creates some ethical dilemmas. Particularly after the acute phase is over, right? You're trying to figure out, well, how much do we go on, and when is this too burdensome, and all those issues come into the forefront. So yes, it's not. There's some very serious issues to be considered, no doubt.
And this pandemic has certainly brought up many ethical issues in terms of resources and whatnot. But I just want to thank you both, because as the alien who's landed on Earth, I feel like you have walked me through not only what ECMO is, but some of the challenges that are involved in getting it started, and also some of the even though some of these discussions are nuanced and there's not data, I think we came to more of an agreement on the things we should be doing rather than disagreements on things. So for me, it was a very helpful discussion. I learned a lot, and I really want to thank you both for taking time out and being part of the discussion. Before I turn over to Adam, I will say that I've been looking at the chat, and every time there was a question, you guys have answered it. So I think we've answered all the questions in the chat. We're finishing right on time. I couldn't think of a better critical care lounge. What do you think, Adam?
I totally agree. The one thing I learned, you can't talk about ECMO in an hour. There's so many more things I want to discuss. We didn't touch sedation. We didn't talk about anticoagulation. We didn't even talk about complications. I can go on and on and on. But I hope you guys, your calendar's free coming up, because we may be calling on you again.
Part 2.
But it was great. I really loved it.
Thanks you both for being here. We really appreciate it.
Thank you,
Adam. Another critical care lounge under the belt. That's number 3 for us. We started off with what did we do? Refractory hypoxemia was first, and then echo. We had echo, and then and now we're left with ECMO. And what are we doing next? Because in 2 weeks we're gonna do this again. Remember, every 2 weeks we're doing these critical care lounges. What are we doing next, Adam?
So I'll tell you, but I reserve the right to change my mind.
Okay, fair enough.
We've done that before.
It's your show too.
I think let's flip it a little bit and let's do a neuro topic. And I was thinking maybe status epilepticus and go from old news to what's new and how do we approach it and what is it and what do we need to think about.
Going brainy on me. We're going neuro. Okay. All right. Well, we'll have our we'll be inviting some guests on, so stay tuned. We'll get everyone invited for the next one, and I think we're going to be doing it. Stay tuned because we're still fine tuning what day we're doing it, but I think this time on Wednesday seems to be a good time for now. So we'll be putting the advertisements out soon, but we're going to be talking about status epilepticus, same format. So if you're enjoying the show, do me 2 favors. First of all, hit the like button and subscribe to the channel, and don't forget to check criticalcarenow.com for any updates that we have, and come with questions. We want these to be as interactive and engaging as possible, and who knows, maybe as these go on, we'll bring you up right from the audience, right up on stage to hang out with us. That'd be pretty cool, huh? All right.
That's and that's I think what sets us apart is we really want this to be interactive, and we want our audience to ask questions, and this is not just another podcast to listen to on your drive. We really we strive for that. So please bring your questions.
We want you to have access to us and the speakers as well. So please feel free to stretch your legs out in the lounge and ask whatever questions you want. All right, Adam Green.
All right.
It's good to hang out with you as always. Be safe, be well, and everyone out there, don't forget to like and subscribe to the channel. And we'll see you in 2 weeks talking about status epilepticus. Have a good night.
Good night, everyone.